All right.
You guys can hear me?
Yeah.
Yes, we can.
All right, great. Mark, you might remind me, or Mike, how much time we have for the talk?
1 hour, Brennan. So we'll have you go maybe until 45 past, and then open it up for some questions.
Yeah, that works.
Great.
Yeah, I have a submission. It won't fill the screen. That's very interesting.
It's okay. It looks good.
Cool. Yeah, we'll give everyone a few more minutes to join as numbers are increasing. I hope you all can hear me. Let me just put in the chat. Great. Wonderful. And we'll give it another 2-3 more minutes. Happy to start the intros. Great.
Good, John.
Awesome. And yeah, just as a reminder, I see a
Hello,
lot of you have
everyone.
an account.
Can hear me?
Yes, you can.
It's me.
Hi, May. Welcome.
Are you able to hear us?
You guys can hear me?
Yes.
All right.
Yeah, we can hear you, Brennan.
Great. Yeah, just as people are coming in, as you know, if you want to, chat or talk during Q&A portion, you will need an account, and you can do that on the top right of your spatial screen. It probably says login, but that doubles as a create an account button. And some of you may have understood this already, but you can use the WSAD keys to walk around the space. You can click and drag with your mouse, assuming you're on a desktop, to look around. You also can click to where you want to walk. And you can click into a seat and sit down. But feel free to take a spot and get comfortable. You'll be able to look at the screen that we're sharing. And again, if you're on desktop, you should see a miniature version of the screen on the top left. Clicking that will bring the screen into your center field of view, so it might be a bit easier. With that said, Mike, should we get started?
Yeah, kick it off, John.
Sweet. Make it look like I'm presenting. Perfect. Well, thank you all so much for attending our inaugural AMXRA Grand Rounds in the Metaverse. As I kind of just quickly mentioned, a couple housekeeping items that may be relevant to a Metaverse hosted event. You can sometimes see our face with the little camera, but for the most part, we all get a random avatar. If you do have a random name on your character, that just means you don't have an account. And if you do want to chat or talk over audio, you'll need to create an account. So feel free to do that while I am doing the introductions. And obviously use WSAD to move around, and you can click to walk to different locations. I just ask that, during the presentation, just feel free to stay muted, and we'll open up the floor for Q&A after the event. But you can totally put a message in the chat during the talk, and we can get to it after the end of the presentation. The talk itself should take about 45 minutes, and then we'll open up the time for a quick Q&A. And if you're so inclined, we have a short survey at the end of the event to hear some feedback. With that said, it's my pleasure to introduce Mike Zapata, who is the Vice President of Research at AMXRA and an Associate Editor of the Journal of Medical Extended Reality. He's also a staff hospitalist at Brigham and Women's Hospital, an instructor of medicine at Harvard Medical School, and faculty at the Healthcare Transformation Lab at Mass General Hospital, where here he conducts research into how technology can improve patient care delivery and trainee education. Before joining, he earned his bachelor's degree from Harvard and his medical degree from Washington University in the St. Louis School of Medicine. He then completed his internal medicine residency training at Brigham and Women's and Harvard Medical School, followed by a Healthcare Innovation Fellowship at Mass General Hospital. Also, he's the inventor of several digital clinical decision support tools that are actively being employed at Mass General Brigham, and he has presented his research nationally and published in many peer-reviewed journals. With that said, it's my pleasure to welcome Mike to the stage.
Thank you, John. Can you hear me okay?
Yes.
Great. Thank you, John. Thank you to all of our attendees from all over the world. If you're logged in, please send us a message in the chat saying where you're joining us from, and if you're joining by a browser or within the spatial VR environment. Like John said, if you don't have access to the chat right now, it's probably because you are not logged in, and you're able to log in by clicking the login button in the top right corner of your screen and following the prompts to create an account directly within this environment, and then you'll be able to participate and send questions in via chat. So thank you all so much for joining today. I have the very distinct privilege of introducing our inaugural AMXRA Grand Rounds speaker today, who is Dr. Brennan Spiegel from Cedars-Sinai. He is a professor of medicine at Cedars-Sinai in Los Angeles and a leading figure in digital health research, serving as Director of Health Services Research at Cedars-Sinai and the George Dorothy Gurich Chair in Digital Health Ethics. He directs the Cedars-Sinai Center for Outcomes Research and Education, focusing on leveraging digital health technologies like wearables, smartphone apps, virtual reality, and social media to enhance patient-doctor relationships, improve outcomes, and reduce system costs. Dr. Spiegel's team pioneers digital innovations, notably developing one of the largest medical VR clinical programs in the U.S. and laying the groundwork for the new field of medicine we call medical extended reality. As a prolific author, Dr. Spiegel has published extensively in the medical literature and is recognized as a top influencer within the realms of digital health and VR. His work has garnered significant media attention in outlets including the New York Times, Bloomberg, CBS News, Forbes, Huffington Post, Los Angeles Times, NBC News, the Washington Post, and the Wall Street Journal, to name just a few, in addition to numerous literary accolades, including Wired Magazine's recognition of his book, VRX, How Immersive Therapeutics Will Revolutionize Medicine, as one of the top 8 science books of 2020. Beyond digital health, he conducts research across multiple healthcare domains and has secured funding from prestigious sources, including the NIH, the Robert Wood Johnson Foundation, and the VA. He was also the immediate past editor-in-chief of the American Journal of Gastroenterology, the leading clinical gastroenterology journal in North America, and is the current editor-in-chief of the newly minted Journal of Medical Extended Reality, the official medical journal of the AMXRA. Dr. Spiegel holds a bachelor's degree from Tufts University, a medical degree from New York Medical College, and an MPH from UCLA. He completed internal medicine residency training at Cedars-Sinai, followed by gastroenterology fellowship at UCLA. He maintains an active clinical practice, teaches at Cedars-Sinai, and is a sought-after speaker at national and international conferences. We are extremely fortunate to have the opportunity to learn from him today. Dr. Spiegel, thank you so much for taking the time to speak with us. I'll hand the floor over to you.
Okay, well, thank you very much for that kind introduction and for the opportunity to speak with you guys today. Make sure I'm getting this working and share my screen. Okay, good. You guys can see that okay up on the screen? A little bit small where I am, but hopefully you can see that okay. All right. Just want to hear some feedback. You guys see it?
Yeah,
yes?
We can see it.
Okay.
Yeah.
All right, guys. Well, thank you very much. It was really a pleasure to be with you today, to be the inaugural speaker in this, I'm sure, first of many future AMXRA talks on this new field of medicine that we all love and call MXR, or Medical Extended Reality. I'm going to give a talk that I recently gave at the FDA MDIC conference just last week, and a version of this a couple weeks before that at our virtual medicine conference. I'm going to mix and match a few different topics, but because this is the inaugural talk, I thought it would be helpful to really talk about the history of this field and to talk about how we can advance the science together of medical extended realities. I call this bridging imagination and evidence. This is a picture of me with a patient. I often use this picture to start my talks because it reminds me why I'm doing this anyway. It's really, for me, about patient care and about improving the lives of the patients we serve. I know many of you are interested in simulation and education, and of course, those are other important applications. I'm going to be focusing today on some of the work I've done on treatment, but we'll be talking about other topics as well. And so just for starters, a conflict of interest. I'm co-founder of VRX Health. This is a startup out of Cedars-Sinai that Cedars-Sinai helped to support for products that come out of the research that we do here at Cedars-Sinai. All right. So I'm going to start with this picture just to orient us. This is where I grew up and where I'm standing right now in Los Angeles, except this is a picture from 100 years ago. And I'm showing this because it's incredible to think about where we've come from in so little time, to allow us all to be sitting virtually in a room like this with a crescent moon behind us, with floating chairs, with pastel colors all around us. Some of you are on virtual reality headsets. But 100 years ago, this is how we got around. This is what the world looked like. Just recently, I was driving around the same streets, and I took this photograph of a Cybertruck. I'm sure some of you are seeing Cybertrucks starting to pop up around you. A vehicle that, of course, like other Teslas, can drive itself. An impossible concept 100 years ago. Really, even 20 years ago, 10 years ago, was still seemed pretty distant. And so it just points out just how incredibly fast we've moved. I really like to show this picture from Ray Kurzweil, who is a famous futurist. And this is a linear plot showing the events from the beginning of life, from the Big Bang, 13.8 billion years ago, we think, to life, a little around 4 billion years ago, and then eukaryotic cells, and then reptiles. And then look what happens here. All of a sudden, in the blink of an eye, evolutionarily, we turn this corner to stand up. And then the next thing you know at evolutionary time is we have an Apple Vision Pro. Okay, next thing we know, we have advanced computers, we have artificial intelligence. The rate of growth in our field and other technological fields is just mind-boggling. That's something I wanted to start with to help frame where we've come from and where we're going when in relation to medical extended reality. And of course, all of this has been enabled by Moore's Law, famously described by Gordon Moore in 1965, who's the co-founder of Intel, when he said the number of transistors on a chip will double approximately every 2 years. And this is a logarithmic plot, not even a linear plot. So the fact that it's linear shows that this is an exponential growth in the calculations per second per $1,000 that we've been able to achieve over time with massive leaps and bounds in technology. And of course, this has enabled all manner of advanced computer systems. And now we're getting to the point where we're going to potentially hit what Ray Kurzweil calls the singularity. And so we started from a black hole, we started from some singularity, I should say, with the Big Bang, and maybe we're going to end in the singularity. And this is this famous book from Ray Kurzweil from around, I think, 2005, when he predicted something. He said, if we look at human intelligence over time, it's pretty stable. I mean, think about Da Vinci. He was just as smart as anyone now or anyone ever. We haven't gotten that much smarter. Our brains haven't changed all that much. But somehow we managed, as groups of individuals, to supersede any one person's intelligence and create incredible machines. And now what we've done is we've taken the inorganic substances from which we somehow were born and are turning them into computer systems that are able to store our knowledge and then think for themselves. And the singularity is this point that he predicted would occur in 2045 when computers would outpace humans, we'd have artificial general intelligence, and we would reach this transhuman period. We may be getting there sooner. This is a whole other discussion for another day, but we're riding this exponential wave, and it's going faster than anyone could have imagined. This is a famous quote from Bill Gates. Most people overestimate what they can do in 1 year, and they underestimate what they can do in 10 years. I think we should revise this and underestimate what they do in 6 months, maybe 3 months, maybe 3 weeks. It's getting shorter and shorter. Things are happening so quickly. I think about when I started this work back in around 2015. This is a picture that we took of one of our patients using virtual reality. And it's still a great picture, and I use it a lot because of his emotional reaction. Here's a patient who moments before was in severe pain from sickle cell anemia, but at this moment he's flying over fjords in Iceland. But look at that, look at the picture. This is a Galaxy S7 phone snapped into a Samsung Gear VR headset. That's ancient technology. I mean, we've gone from that to having stuff like this. So hopefully the video is working on your screen. This is a project we've been working on here at Cedars-Sinai called Zaya. This is an extended reality artificially intelligent ally. She's a robot, and patients can talk to her in the Apple Vision Pro. Uses 6 different forms of AI to generate realities around you. We call that GR, or generated reality. And based upon what you're talking to her about, she will create different environments. We wrote this paper recently describing our initial experiences in combining spatial computing and AI in this case for helping to support anxiety and depression through psychotherapy. But the idea here is that there's just no way I could have imagined this like 3 years ago, that we would have some kind of robot system using 23 million pixels on the Apple Vision Pro and talking using natural language processing, generating worlds around you using artificial intelligence, when just a few years ago we were using the Samsung Gear VR with the Galaxy S7 phone. This system, by the way, can go a step further. That robot, after talking to the human, can write a note. And it's a clinical note that goes right into the chart. This is an actual note that this robot has written to help our psychologists here at Cedars. We have 1,000 beds. We have one psychologist who's trying to get around all these patients who need his help. And so if we can deploy Zaya, she'll write a note, put it in his inbox, and now he's a step ahead, ready to go see the patient. So again, this is just an example of how massively fast we are moving in this field, and that's the first main theme that I want to get across today. And again, you can look at the details in this note. It's certainly better than the notes that I write, to be honest. That's certainly better than notes my students write. In this case, it's a psychology note. So what's going on, of course, is technology has been progressing over time. But we tend to think linearly. This is well established that we think that tomorrow will be a little bit better than today, and the day after a little bit better still, but it's going to be linear, and things tend to be predictable. But then we're shocked when actually we end up over here. And this is called the exponential growth surprise factor, where we just didn't see it coming. But we have to start seeing it coming. And people like you all on a talk like this are recognizing that there's an exponential curve that we're on. You can even see that if we do a PubMed search and look at the papers that have been published using the term virtual reality on PubMed. Look at how exponential the rise has been. If I were to draw a similar graph for the term artificial intelligence, you'd see the same exponential rise. So this is enabled by Moore's law, and then enabled by really creative people like you and others who are thinking about ways to apply these technologies in clinical practice or for training or simulation or therapeutics. Now, when Wayne Gretzky was asked, how are you so good at hockey, best hockey player ever, he famously said, well, it's really easy. All you got to do is skate to where the puck is going, right? Don't skate to where it is or where it's been. You skate to where it's going. And that requires some predictive validity. That means you have to know where the puck is going. And we have the added complexity that the puck itself is speeding up. It's not a stable speed or slowing down. It's going faster and faster and faster. So we have to get out in front of that puck. So with that in mind, what I'd like to do for this part is give a little history of the technological progress that we've seen with medical extended reality. And this part is similar to a talk I gave recently. Then I'm going to talk more as we get farther over to the right about what our challenges are now, especially for a society like AMXRA and its members. What does the future look like? How do we chart the progression of what I'm about to go through with you? So it goes back in time to the 1950s. I call this the foundational era. And I'm going to break this timeline up into different eras to help tell the story of MXR and its evolution. And really, it all began with these foundational discoveries using stereoscopic screens to create fantastical, amazing, immersive experiences. The Sensorama, as far as we know, is the very first example of this, created by this really creative guy, Morton Heelig. And he was in New York, and he created this big console, almost like an old Atari game or arcade game, where you would sit in it, and you can see a picture of his patent on the right. And it felt as if you were on a motorcycle driving through the Bronx in New York. And if you look up at the top, it says on the console over above that this is 3D, and there's stereo sound, vibrations, aromas, and wind. That's pretty incredible. He was doing haptics. He was doing multi-sensory experiences. And this was really thought to be the first example of what we now call virtual reality. In fact, on his gravestone, it literally says that he is the father of virtual reality. And there's been some others I've heard that claim to be the father. I don't know. There seem to be a lot of fathers of virtual reality, but he, I think, is the very first father of virtual reality. Of course, there were others involved at this time. There was something famously called the Sword of Damocles. This was developed by Ivan Sutherland, and he's created this setup where this kind of mechanism hung from the ceiling, and the stereoscopic lenses would come down, and you put your face in it. And it was quite amazing at the time because you would see objects floating out in front of you, like a cube, for example, would float out in front of you. And it was a remarkable thing to see and experience some objects floating out in space in front of you. So this, again, was another major advance. Now, with the discovery of stereoscopic images and multisensory immersive technologies, there was this period that continues till today of technological advancements and scaling. And really one of the most important people during this era was Jaron Lanier, who created the first commercial head-mounted display. And I'm going to show you now, and hopefully you can hear this because I think the sound's been a little bit funky, but hopefully you can hear this video of him, which really, it's only about 30 seconds long, of him talking about this technology in the early 1990s. So hopefully you can hear this.
Well, this is our virtual reality glove. It's called a data glove. And the idea is that you can put on this glove, and the glove lets you feel a world that doesn't exist as if it's real and pick up things in the world as if they're real. So it lets you reach into an imaginary world. And these are the special glasses called the iPhones that you put on. And when you put them on, you're seeing inside an imaginary world instead of inside the physical world. So the idea is that by wearing computerized clothing right over your sense organs, you transport your sensory system into a reality that can be of any description.
Really quite an incredible interview. There's a few things about that. You might have picked up if you heard that he did call that the iPhone. Called that the iPhone long before 2007 when Steve Jobs revealed the other iPhone. Of course, he was talking about EYE phone, not an iPhone. But he called it the iPhone, and he talked about using computerized clothing over sense organs to transport you to fantastical worlds. A really incredible vision in the early 1990s, and he needs to be credited. He wrote this book, amongst many others, which is really worth reading. If anyone's interested in VR or hasn't read this book, The Dawn of the New Everything, A Journey Through Virtual Reality, where he tells sort of this autobiographical story of how he discovered VR and helped to develop it. It's really a beautiful story. And one of the vignettes in the story that I particularly like is when he was first testing out VR in his lab, he used to bring out a rose or some flowers. And as people would come out of the VR, he would put the flower right in front of their face and have them smell it and look at it. And he said, actually, they looked at the rose differently. They said it was just so impossibly beautiful, impossibly granular, compared to the headset that they had just been in. So in a way, the headset was actually allowing them to experience real reality in a richer, more beautiful way. And that was one of the insights I gained from that book, is that if VR is done right, it's really allowing us to live a fuller, more enriching RR, I like to call it, real reality. And we don't want necessarily everyone living in virtual reality. People think about dystopian futures like Ready Player One. The idea of VR and XR in general is help people live fuller, more meaningful, real realities. Now, as the technology evolved from that early iPhone, as he called it, to headsets where you snap in a smartphone, to more advanced headsets like those developed by Meta or HP, this started to occur. And then eventually, more recently, we got to this remarkable device. It is truly an incredible device. I don't know if any of you have used it yet. I'm sure many of you have. 23 million pixels, no hand controllers, just uses eye tracking. It really is a beautiful, incredible device. And although I'm sure there will be improvements and the cost will need to come down over time, it is truly a quantum leap in the capability of mixed reality spatial computing. So we've seen this incredible advancement. Once we started developing these technologies, then we got to this period of therapeutic pioneering. And this was made possible initially by looking at psychological applications. by people like Skip Rizzo and Tom Furness, Hunter Hoffman, Diane Grimala, Walter Greenleaf, Brenda Wiederholt, and many others not shown here. It's important to me that we recognize the people that made this possible for us to be in a place like this talking about this. And these are some of those individuals. Really want to point out, especially for those that may not already know about this famous work by Hunter Hoffman. This is the famous Snow World. What's amazing if you look at this is, of course, really old graphics. The graphical user interface, pixelation, not that great as we stand here today. But it didn't matter. It was still enough for people with advanced burn injuries undergoing bandage changes at the University of Washington, for example, to have reductions in their pain experience, just from the immersive environments of being in this cool, snowy world to metaphorically countervail the searing hot pain that they were going through. And these are some of the studies on the right. And this is one of my most sort of favorite studies in all of VR, from Schmidt and colleagues, 2011, burn injury patients going through the bandage dressing changes as they're getting exposed to this snow world. And what you can see here is that not only did it reduce the sensory experience of pain, that's the black bars, but also the time spent thinking about pain and how unpleasant the pain was. So that's not just physical, but also cognitive and emotional components of pain. And they also had more fun. And fun is a real outcome. Like, fun is a real thing. And people do have fun in VR, and that's okay. There's, at the time, some critiques this outcome as not being very scientific. I think that's nonsense. Nothing wrong with measuring fun. And what's amazing is when they later looked, or actually earlier in 2007, looked at the brain of people experiencing VR in Snow World, when they were experiencing pain on the left, you can see the functional MRI signals lighting up in the sensory cortex and also in the limbic system, and right there in the middle in the hippocampus and the insular cortex, showing that pain is not just a physical painful experience, but an emotionally painful experience. And when those same individuals were exposed to Snow World and re-imaged, they would see a reduction in the signals, both in the sensory cortex and in the emotional centers. Now, the additional work was conducted to look not just at acute pain, but chronic pain. And this is a foundational study in our field by the folks here at Applied VR down the street here in LA. I don't have any financial relationship with them, just to be clear. They did go through the Cedars-Sinai Accelerator, but that didn't benefit me. So just to be clear about that. But in any event, they created this program called EaseVRX. And in this study, which led to the FDA clearance of their device, had an 8-week treatment period where they monitored them and their pain over that time and demonstrated a separation in favor of pain compared to sham VR. And that was the important thing, is they also had a control condition where you put on a headset, but rather than being immersed, you looked at these two-dimensional screens. And we're going to be putting out some new studies soon, looking at other populations and whether this works in those populations. I look forward to presenting those findings very soon. One thing that we often think about when we see people getting better from virtual reality is what's going on in their brain exactly. And how does something like VR help a patient going through a burn dressing change feel better? And this is the Glass Brain by Adam Gazzaley at UC San Francisco. A beautiful demonstration that the brain is not some block of Play-Doh that rattles around in our head all day. It's a shape-shifting organ like any other organ in the body. And it changes. And virtual reality can change it. These are some of the brain networks that are being lit up. And one thing I often say is even when we are in physical distress, we can still modify how our brain perceives our body. And VR teaches us that. That's one of the big insights from this period of research. Now, other work at this time included the very famous work from Skip Rizzo, Braveheart. This was research that he did at University of Southern California, demonstrating how he can recreate extremely stressful environments, war scenes, and then recreate the environments that cause PTSD, that cause those stress reactions that people experience long after they leave the battlefield. and through exposure therapy, continued to allow people to practice over and over again so they can learn how to modify their bodily response to these emotional stressors. His work really showed me that VR can serve as a conduit for healing, allowing us to confront and reprocess our most traumatic and difficult memories. That's a really profound insight. Now, at this point, there was a lot of advancements in therapeutic pioneering, but the next area that I want to focus on is this area, this era that I call the empathy machine. And I didn't come up with that term. Chris Milk did, and I'll come back to him. This notion that VR and XR can allow a sense of empathy by putting yourself in the shoes of others. It might be putting yourselves in the shoes of a patient and feeling what it's like to be a patient. It could be putting yourself in the shoes of a surgeon and feeling what it's like to do an operation, or in any number of other individuals. And so this was the era of virtual embodiment. And this really was made possible by many different people, some of whom are shown here. Mel Slater at the University of Barcelona did a lot of this work, and I'll show you that in a second. Mavi Sanchez Vives, also at the University of Barcelona, and I'll show you some of her work. Courtney Cogburn in New York, Jeremy Bailenson at Stanford. These are just some of the individuals who should be credited for doing work during this era to really advance our understanding of virtual embodiment. I first learned about virtual embodiment firsthand when I visited Mel Slater and Mavi Sanchez Vives at the University of Barcelona. And I went to their laboratory, and in their lab, there's all these different rooms. This is one of the rooms. And it's an interesting room. It's got a chair and a table and some black draped walls. And they had me sit down in the chair and asked me to kick my feet out onto the table, which I did. And this is Ramon Olivas, who at the time was a postdoc. This picture is taken around 2018, maybe. So it's quite a while ago now. And so then what they did is they put a headset on me, and I looked up, and next thing I know, I'm looking at this room. And there's this beautiful living space with wood paneling, big chandelier. And I look and I see, oh, like, look at that, there's some legs there. And they're right where my legs are. And I think, whose legs are those? And then what they did is they drew some blue lines on the table and asked me to move my legs to trace out the blue lines. And sure enough, in perfect one-to-one synchrony, when I moved my legs in real reality, these legs moved in virtual reality. And that was wild, because I thought, man, it sure feels like my legs. But I knew there was a computer in that room running thousands of lines of code, convincing my brain that I was in those legs, like a digital parlor trick, kind of like the Matrix. And then what he did next is he dropped balls from the ceiling. As each ball hit my body, I can feel it vibrate, because they had put haptic motors on my ankles and wrists, and they were synchronized. What happened next, I always tell the story. It's hard to even explain it in words, but I'll show you what happened next. What happened next is they separated me from me. Next thing I know, I'm being pulled out of my body, floating slowly up to the ceiling as these balls continue to hit me, reminding me that I'm still a self. But I looked down and I noticed that body that I just occupied was motionless. I had died. I was having a complete and total out-of-body experience. And here it is again. This is an amazing thing, a fantastical thing. And every time I tell the story, I just flash back to what it felt like. I remember thinking, that's so interesting to look down on my dead body and to realize that the process of dying need not be catastrophic. I don't want to die, but the moment of death isn't necessarily a catastrophic moment. And that was really a profound experience that a VR headset in a lab in Barcelona gave me. And so, in fact, he's shown this. This is a randomized controlled trial called a virtual out-of-body experience reduces fear of death. How crazy. This was a study where he randomized people to the experience I just described versus a similar experience where you do float up to the ceiling, but you look down and you can still move that body down there. In other words, you're just looking at yourself from the ceiling. And then a week later, he asked people about how afraid are you to die? They had no idea that was going to be what the study was about. And those who experienced the out-of-body death had a lower fear of dying. Profound stuff. So this points out that VR really is a tool for perspective taking, whether it's being used for simulation or for education or for empathy. It is a profound tool for perspective taking. And when we use it to recalibrate unhealthy perceptions, VR and XR in general becomes a radical new therapy to improve quality of life. Now, I'm going to show you another very powerful example of virtual embodiment. And this is also from the same visit at the University of Barcelona. This is from Mavi Sanchez Vives. And what she did is she also had me put on a headset and embody another body. But this time I became a woman. And I looked in the mirror, as you'll see in a second, and I looked different. And I found myself in this room when this dude shows up, comes busting through that door, and this is what happens next.
Have you seen yourself in the mirror? I mean, where do you think you're going looking like that, huh? Shut up. You could put some effort in and dress up or something. Look at me. You look 20 years older than you actually are. Do you know, there's not one woman out there who looks as wretched as you do right now. I said, shut up, you fat cow. You're disgusting. Aren't you going to say anything? I said, look at me. Yeah, of course. Typical you. This is all my fault.
All right, so it's pretty profound and shocking. And just imagine being in that situation. I will say that ever since then, I do think about domestic violence differently. I've always had empathy towards that, but now I can at least say I've simulated what it's like. I can't pretend to know what it's really like. I have not been exposed to that personally. But having been through a simulation, it changes my understanding of it. In fact, this has been shown in an incredible study by the team there in Barcelona, where they took offenders of domestic violence in the Catalonian correction system, and they exposed them to their own medicine, actually made them become the victim. In a series of very elegant and interesting studies, they were able to demonstrate that it changed their perceptions of others in a way that ideally would reduce the chances of them committing this crime in the future. And so there's a lot more to be said about this particular study, and you should check it out if you're interested. Chris Milk sums it up really well. VR connects humans to other humans in a profound way that I've never seen before in any other form of media, and it can change people's perception of each other. And that's how I think virtual reality has the potential to actually change the world. So this is not just a platform for gaming or for entertainment, something a lot of people outside of this room might imagine. This is about changing the way people interact with one another, think about themselves, think about the world around them. And that's what medical extended reality for me is all about. This is another example where here we use these very old Homido clip-on VR glasses on a smartphone and worked with a church in South LA to help reduce blood pressure. In this case, we were approached by Pastor Calvin Sauls of the Holman United Methodist Church, who said he had a problem. Too many of his parishioners were developing strokes and heart failure, high blood pressure, and he wanted to do something about it. So we ended up working with him and the parishioners to create a culturally tailored hypertension management program in VR that just runs right there on the smartphone itself. And the whole idea was you would go into this beautiful space, into a kitchen, and there were different meals that you would open up and look at, and it would tell you how much salt in particular was found in these meals. And then you would go flying through your body, through the heart and the arteries and the brain and the kidneys, and watch in this pretty dramatic experience as the blood pressure started to erode the organs and the salt made things worse. Then you would come back after this journey, go out on that beach beyond and pray with the pastor in VR and make a decision with him. Do you want to continue your ways with eating and with salt? Or are you going to be able to change your diet? And actually, this reduced their systolic blood pressure by 7 points in an uncontrolled case series. So another area of really interesting research. In our first virtual medicine conference back in 2018, the pastor came on stage. He said, I love technology. Don't get me wrong, I'm all about high tech, but that has to be accompanied by the personal touch, by the holy touch. It's not just about putting a screen in front of people. It's about inviting people into catalytic spaces so they can participate in meaningful engagement. So powerful stuff during this era of the empathy machine. And now I want to move to this last era. I call this the rise of MXR. Now, there are other potential eras of somebody else for giving this talk that we could put into this timeline. But I really want to move now to what I call the rise of MXR, the period of MXR validation and codification. And I want to start with validation. How do we develop software programs that work, that people want to use? And, to get us into the mood for this part, I want to show this picture of the technology adoption lifecycle made famous by Everett Rogers in his book, Diffusion of Innovations from 1962. And this book is full of incredible insights that we still use today. And one of the insights he had was that there's different kinds of people in the world. And those of us who are on this call today are probably on the left side of this curve. We like technology, we're technophiles. We're the first to maybe buy and use a technology, call that the innovators. But if something's really going to be scaled, it has to jump over what he called the chasm. There has to be enough people using the technology and enough early adopters to get to the point where it starts to spread. Then you get to the early majority, late majority, and the so-called laggards. So how do we create things that people are going to want to use? If you build it, they will come. This is made famous by Kevin Costner in this movie Field of Dreams. I have to say, I did show this to some of my students in our grad school, and most of them, I think all of them one year, had not heard of this movie. So kind of maybe some of you haven't either. I'm starting to feel old. But he had this saying in it, if you build it, they will come. I'm here to tell you, if they build it, they will not come. Just because we build an app does not mean anyone wants to use it, does not mean that patients want to incorporate it into their busy lives or surgeons want to incorporate it into their clinical practice. We have to have a way of co-developing software with the end users in mind. And one key point is that digital health is not solely a computer science or an engineering science. It is also very much a social and a behavioral science. So it's important to have people on development teams who recognize these principles of behavioral science, and particularly the principles of human-centered design thinking, because that's a lot of what we're doing when we make apps, is we're following the design thinking 101 principles of understanding, exploring, materializing, empathizing, defining, ideating, prototyping, testing, implementing. And there's a whole science around this. This is a book that we've used with some of our graduate students here at Cedars-Sinai to teach them about health design thinking. And this is a really good framework that I show all my students. They all have to read this, called the IDEAS framework, which is a toolkit for strategies for developing more effective digital interventions to change health behavior. Definitely check this out if you haven't seen this before. Lots of great steps that they have in this about how to do this work. And if you go back even well before even the smartphone, there were all sorts of great publications from the federal government, from ARC in particular, on guidance for how to make better apps. So this goes back a long ways. I am always a little bit perplexed when people start making apps like they just sort of know what people want and what they don't want, but there's a whole science about this. You don't need to off-road. It's better to follow the script and do it the right way. This is a paper that we published several years ago called Recommendations for Methodology of VR Clinical Trials in Healthcare. This was done by the so-called VR Core group. Brandon Burkhead was the primary author. He was my graduate student. He's now on his way to Apple, which is great for him. We're excited that he's heading to Apple. He's just finishing his psychiatry residency at Johns Hopkins and is also a proud member of AMXRA. And in this document, which was created by an international group of experts in the field, we described 3 different stages for validating new programs in XR. We called it VR1, VR2, and VR3. Maybe it should be XR1, 2, and 3. Just like FDA has 3 phases of clinical trials, the VR core recommendations include 3 phases of validation. And the VR1 study is really about human-centered design. It's about sitting down with your stakeholders, whoever they are, talking with them. What do you want to see? What are your unmet needs, knowledge, attitudes, beliefs, preferences? Really talking to them. And these are some steps that we describe in the paper for how to do this work. This is an example of a paper that we published where we followed some of the principles of a VR1 study. It's literally called a VR1 study. Here we developed a program to help people with irritable bowel syndrome. And as we got to talking with patients, they gave us all sorts of interesting ideas or visualizations and metaphorical environments where they can learn things. In this case, we started to develop a robot that somebody recommended, which is a robot avatar. And then we would develop these things, in this case using Unity. This is work by Dr. Omer Liran here at Cedars, who's been developing these environments. And then a VR2 study is once you have the program initially developed, is to do an initial uncontrolled case series to look at feasibility, acceptability, tolerability, safety. And these are some of the steps involved in doing that. Again, I'm not going to read all of this, but you can read the paper. And finally, get to the VR3 phase, randomized controlled trials that are properly powered, looking at clinically relevant endpoints. This is an example of such a study we're doing right now. We actually just finished this study. We'll be reporting out the findings soon, funded by the NIH, a 3-arm study looking at sham VR versus distraction VR versus skills-based VR for patients with chronic lower back pain. And we published our full protocol ahead of the results, which will be coming out shortly, to give a sense of what a VR3 study should look like. And these are more of the criteria for a VR3 study. So if we follow these criteria, I think if we build it, then they are more likely to come. But it's not a guessing game. We have best practices for how to do this stuff. Finally, I want to end my comments now by talking about this era of MXR codification, really bringing the field together, moving it forward together into this new era. And there's lots of evidence that this has been occurring. This is an infographic from, on the right, March of 2020. That's just when the pandemic started. This was the first FDA public workshop that brought together Microsoft, Facebook, Cedars-Sinai, we were there, and Hopkins, Stanford. Very interesting bedfellows coming together. And this was the beginning of medical extended reality, MXR. This is where that term really was born. Just last week, we had the second of these. Now it's run by the Medical Device Innovation Consortium. On the left, the US FDA page on MXR. It's really been exciting to work with colleagues at the FDA and to be a part of this new field expanding. This picture of this guy back here is not random, by the way. That's Ryan Beams. He's been central to the work at the FDA, and he's also an associate editor in our new journal, the official AMXRA Journal of Medical Extended Reality. Of course, things like this have happened to further codify the field. We're all here today because of Mark Zhang's vision to develop the AMXRA. And of course, Bob Fine has been vital in moving forward our field as well by establishing the International Virtual Reality Healthcare Association, or IVRA. And then we're so proud to have our Journal of Medical Extended Reality. Spread the word about our journal. We've been so excited to see so many people now supporting the journal. In it, we wrote this introduction. We also have this incredible international board of editors, some of whom are here with us today. What's exciting is not only is it international, but we have the NIH involved, the FDA is involved, the VA, of course, Mark's now at the VA, is involved, and some of the who's who of medical extended reality are participating and supporting our new AMXRA journal. So please think about the journal. If you have research that you want to publish, reach out to me if you have any questions. This is now an outdated slide. I mean, I've already seen that we now have over 5,000 downloads year to date since January. The really exciting thing is we're going to start publishing AMXRA guidelines in the journal. If you have an idea for a topic that would be a good guideline, let me know. I'm going to start overseeing the guideline development process. We're going to be putting teams together to write guidelines that will be published in the journal. The very first guideline that we published is this one. We figured we might as well start with the basics. What is medical extended reality? And we created a taxonomy defining the current breadth and depth of this evolving field. And so in it, we have this picture, which is MXR in one snapshot, showing everything as we currently understand MXR to be. 5 major pillars. I spoke quite a bit about clinical and therapeutic applications today, but there's, of course, education, training, communication, ethical, regulatory, and socioeconomic considerations, technological integration, including artificial intelligence, and of course, design, development, and clinical deployment. And each one of these little boxes gets exploded out into more topics. There's over 100, I think about 179 individual topics embedded within this that are described in this AMXRA guideline. So I'm going to end with a few pictures. And I want to show you this picture because some people, when they think of VR, they think of this. They think of kids playing computer games, playing first-person shooter games. We need to start changing the minds of people to think more of stuff like this. This is great work from Stanford University, where they've been using VR for years with kids. Instead of pictures like this, which aren't terribly helpful either, we need to start thinking about pictures like this. This is an incredible video years ago was posted of this woman with advanced dementia, who moments before this was taken was crying out in pain and was confused, but then she got a headset on her face and she was brought back to a childhood beach, and then she started to sing songs, and this is what happened.
Gonna see, I'm gonna see, I'm gonna see, I'm gonna see. Beautiful. Oh, look at it. You made this today? Well, yeah. If you didn't come here, see it, you would never know that it's even blue. It is blue. Oh, it is blue.
So this is really how I want to end, with pictures like this, to think about the future of our field, to think about the incredible opportunity to change people's lives for the better, to give them a sense of awe and wonderment and even fun in moments when people are very vulnerable or in pain, to give people a sense of escape from the walls of their illness, from the metaphorical and physical walls in which they find themselves, to give surgeons a better opportunity to take care of their patients with incredible technologies like this one shown here, and to think about ways to engage our patients using technology that never before was possible. So I want to end with this. Our grand challenges for where I really would like to see us continue to go is to continue to unify this field, to bring the groups together so that we can expand it, to advance the science using best practices, to make MXR more accessible to the people that we serve, and ultimately to improve lives. If you're interested in this, I wrote this book, as I mentioned in the beginning. You can check it out for more. And I just want to thank you guys for the invitation to be the first speaker in this series, and to thank all the different people that have supported the work that I've been showing you today. We have many different collaborators. This is a highly interdisciplinary science that we all find ourselves in, and we couldn't do it without our students and trainees and postdocs and collaborators from all around the world. If you're interested in more, I'm on Twitter. You can check that out. And I want to thank you all, especially Mark, for thinking about developing AMXRA as we jointly move this field together. So thanks very much. I hope that was a helpful overview.
Dr. Spiegel, that was a phenomenal talk. Thank you so much. It really did a great job of highlighting the fascinating history of VR and the beginning of very many use cases now evolving within the medical field that will gain more and more relevancy here over the coming years. I saw a similar talk of yours a year or two ago, and the section on virtual embodiment really stuck with me since. I found that part to be the most fascinating, especially your out-of-body experience. I loved it because it has profound implications, as you mentioned, for how both patients and physicians approach the dying process now and in the future, and similar in many ways to some of the work that psychedelics have been shown to alter perspectives around end of life for many patients. Huge potential to drastically improve the level of care that we're able to provide in specialties like PAL care, oncology, et cetera. So truly fascinating. That has always stuck with me. I don't see questions in the chat just yet. So if anybody has a question or two, please drop it in the chat now, and we'll try to review here in the last 3 minutes. But I'll ask a question to kick things off. Just wondering what you, Dr. Spiegel, think are the biggest barriers to adoption right now, and successful strategies that you have seen work to overcome implementation of this new technology in the clinical sphere, given your successful clinical service at Cedars-Sinai that employs VR regularly.
Yeah, I think it always depends on which part of MXR we're talking about. But if we're talking about clinical care, I think the barrier is really not having it integrated within care delivery systems. That's something we've been trying to focus on more, is having the computers integrate with the electronic health record and the systems that everyone is familiar with, everyone uses. Having a team that can actually deliver the headsets, clean them, so we don't burden other doctors or nurses. Having clear instructions. Really, a lot of it is around the implementation itself. I think this would be a great area for guidelines in the future, is to help kind of let other people know what works, what are the best practices. Of course, insurance remains a barrier. Making sure insurance companies cover this. We've been seeing some successes there, but we need to really keep pushing on that front as well. And at some point, ideally, AMXRA gets big enough, we can actually go to Capitol Hill and advocate on behalf of our patients to see if we can start to get funding from insurance companies for what often are very cost-effective approaches. So there's just a few thoughts that could come to mind, but happy to hear what other people think too.
Yeah, those make a lot of sense. And it was interesting to see one of your early slides where you actually had some Epic level integration within the sort of system being used, which I'm sure will continue to evolve and improve over time. But that's certainly a good first step to link both the patient experience and the chart for documenting purposes and so forth. But very reassured that, FDA level acknowledgement has occurred over the past few years, and I think that'll certainly help insurance regulations and so forth. So all good things. A question in the chat from John Letourneau. What lessons have you learned from XR technology over the past 20, or compared to 20 or 30 years ago?
Of 20, 30 years ago, let's see, what else have you learned from XR technology of 20, 30 years? I guess I have to understand, like, over the past 30 years, what lessons learned?
Yeah, sure.
Yeah, I mean, there's so many. Like, some of them I think I've tried to point out in this talk, that VR is not just for gaming and entertainment, that it's really giving us access to use our minds in different ways. So I often will refer to like supernatural abilities, and that's sort of a throwaway line to say that. But if you think about it, supernatural means, super means above. If we can give people access to levels of consciousness that they might normally require a psychedelic to access, for example, but natural, we do it in a way that's totally natural. We don't need to even use a medication to give people access to new abilities to think differently about themselves or to learn differently. To me, that's a really major advance for what these technologies can achieve. So that's just one quick thought I have, and probably a lot of others as well.
Yeah, that's fascinating. That's certainly an inspirational way to sort of wrap things up here. We're right at time. Maybe we'll do one more question, Dr. Spiegel, if okay with you, from Gina that just came in, and then we can wrap things up with John. Do you see medical VR being accepted in other parts of the world compared to the US? And if so, what have you already noticed?
For sure, especially in Europe, but elsewhere in Asia too. I've seen incredible work in Europe, especially in the Netherlands. They've done incredible work bringing VR to the hospital, having it connecting to online libraries that work with the EHR systems. They're in some ways really ahead of us, particularly in rehabilitation as well. So yes, I've seen it, and of course in Asian countries I've seen major advances too. Lots of interest around the world, but yeah, I think it's continuing to grow.
That's fantastic to hear. Lots of good things to come, surely. John, I'll turn it back over to you to wrap things up. Thank you again, Dr. Spiegel. Thank you again to all of our attendees. This was a phenomenal first session of many more AMXRA Grand Rounds. So thank you all very much. Back to you, John.
Wonderful. Yeah, again, thanks, Dr. Spiegel. This was wonderful. Really, really great stuff. So thank you so much. Thank you for everyone who attended. I'm just going to drop a quick form in the chat. You're more than welcome to provide feedback. Our goal here is just to always improve our events. So thank you so much for attending, and we hope that you continue to be part of AMXRA, and we'll share more events in the future through our AMXRA channels. Please reach out if you ever have questions. Thank you so much and have a great day.
Thank you guys. Good night.